I'm Dr. Julie Gralow. I'm a medical oncologist, and I'm the Chief Medical Officer and Executive Vice President at the American Society of Clinical Oncology. One of the biggest challenges to getting innovation in healthcare is this kind of institutional inertia. They're comfortable with where they are, and risk aversion with respect to the safety of protecting information, protecting the patient. There's this interplay. The electronic medical record, at least in the United States, was developed in theory to give us feedback real time about what we were doing and how did we match what was going on. And it turned into a billing machine. And so changing the electronic medical record to bring innovation in so that we can accelerate, advance the field, do better for our patients is a problem. One thing we could do is to do protected pilots, to create what we call sandboxes, where it's a safe environment. We're not applying it broadly up front. We're testing innovation in protected ways where it's iterative, we're protecting, we're evaluating what's happening, and then make decisions about whether we're ready to broaden it. So these sandboxes where we can be creative, upfront, try things. Some won't work, some will, that are protected environments. That will be one thing. So sandboxes in which we can test innovation. Number two gets at the cost of how do we test innovation? How do we bring innovation in? Even though the upfront cost might seem monetarily like a lot, we've got to look downstream at what will be the benefits more long-term that will be cost savings, whether it be savings in actual dollar amounts versus savings to patient toxicities, improvements in patient outcomes. So I think we've got to look at how we reimburse in the healthcare system. And the US has a complicated reimbursement system. Other parts of the world do it differently. But we have to be able to look toward reimbursing for the prevention of problems, the prevention of a cancer diagnosis, but the prevention of toxicities. And right now, at least in the US system, you get paid if you're treating a bad outcome, you're treating a cancer, or you're treating a toxicity from a treatment. So we have to overhaul reimbursement. We have to reward for those who practice with evidence and evidence concordant care and value-based care. And we have to figure out the right way to reward the system in practicing evidence-based medicine and preventing diseases, complications, etc.